Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another fascinating guest today who has been helping to create a better tomorrow for the last several decades. Today we have the honor of being joined by Ambassador John Lange, who is a senior fellow in global health diplomacy at the United Nations Foundation, which is a charitable organization located in DC that supports the United Nations and its various activities. Ambassador Lange has extensive experience in global health issues and longstanding involvement in United Nations affairs, focusing on issues related to global health security and the work of the World Health Organization. And he also serves as chair of the leadership team of the Measles and Rubella Initiative. Ambassador Lange, from 2009 to 2013, worked at the Bill and Melinda Gates Foundation, and there he engaged in high-level advocacy with governments and international organizations, ultimately to advance the Gates Foundation Global Health and Development Goals in Africa. In 2012, he was the founding co-chair of the Polio Partners Group, which is a broad group of stakeholders in the Global Polio Eradication Initiative, and served in that role for 4 years. Ambassador Lange additionally has a distinguished 28-year career in the Foreign Service of the United States Department of State, where he was a pioneer in the field of global health diplomacy and a leader in pandemic preparedness and response. He served as Special Representative on Avian and Pandemic Influenza from 2006 to 2009, Deputy Inspector General, Deputy U.S. Global AIDS Coordinator at the inception of the President's Emergency Plan for AIDS Relief, and Associate Dean for Leadership and Management at the Foreign Service Institute, where he was involved in directing the Senior Seminar, the federal government's highest civilian military joint training program. He was the U.S. Ambassador to Botswana and Special Representative to the Southern African Development Community, where he oversaw 7 U.S. government agencies and made HIV/AIDS his signature issue. Ambassador Lange also headed the U.S. Embassy in Dar es Salaam, Tanzania, during the 1998 Al-Qaeda bombing, for which he received the State Department's Distinguished Honor Award for Skill, Leadership, and Extraordinary Courage. Ambassador Lange is a distinguished graduate of the Naval War College with a master's in national security strategy, graduate cum laude of the University of Wisconsin Law School, and a graduate with distinction of the University of Wisconsin-Madison in political science. I could go into a lot of things he's done, but that would take up the whole episode. Suffice it to say, we're honored to have him. Ambassador John Lange, thank you so much for taking time to come on the show today.
Oh, thanks very much for inviting me, Ira. I appreciate it.
Yeah, it's really great having you, John. I'd love to start off, as we typically do, just by handing you the floor for a few minutes to sort of further fill in the gap sort of at the beginning of the story, because you have an amazing career. I'd love to hear just a few minutes of how it all started. What got you interested in political science, in law, and a little bit of sort of the early days? What made you interested in public service and sort of international affairs?
When I was in high school and then undergraduate and college, I actually started out as a mathematics major as an undergraduate, and then computer science. And then I just decided that I was really interested in political science because I'd taken some courses in that. And serendipitously, I had a friend who asked me to become part of the University of Wisconsin Model United Nations. And it was really through that I developed this international interest. I even ended up being the Secretary General of the University of Wisconsin Model UN as an undergraduate. And while I was in law school, I even worked part-time for the United Nations Association of the USA Wisconsin Division. I took international law courses, and after graduation from law school, I really made a fateful decision. I was offered a job with the UN Association in New York, and I decided I was more interested in international affairs, even though it wasn't the legal job that I was offered, than I was in practicing law in Wisconsin. And I've never looked back. I really enjoy the international environment. And while at the UN Association in New York, I applied for the Foreign Service and entered the Foreign Service in 1981. I had tours of duty in order in Mexico City, Paris, then back to Washington for my first tour there, then in Lomé, Togo, Geneva, Switzerland, back to Washington, and then Dar es Salaam, Tanzania, and finally, as my overseas tours go, Gaborone, Botswana, and then back to Washington. But it wasn't until 1999, after I'd been in the Foreign Service for 18 years, that I really started getting involved in public health issues. And that was because I arrived in Botswana, and even as I was preparing to go to Botswana, you could look at this wonderful country in Southern Africa, and from the perspective of a US ambassador, you want to look at the whole panoply of US government interests. So here it was, a longstanding democracy since its independence in 1966, although I must say it was always dominated by one party, but still they had democratic elections, a relatively free press. They were oriented toward the private sector. And in fact, one of the reasons that it's a relatively prosperous African country is that they have diamonds, and they make good use of those diamonds. The company, Debswana, that has the diamond mines, was half owned by the Beers and half owned by the government of Botswana. And as a result, it was operated as a private sector entity, but at the same time, it was giving resources to the government. And they also had a good military. The US military liked working with the Botswana military under civilian control, all of these wonderful things. But when I arrived in 1999, the estimated rate of HIV for those aged 15 to 49 was 38% positive. Now, that was probably an overstatement based on the methodology they were using. It was probably closer to 33%. It turned out later. But that meant that 1 out of every 3 adults you met was HIV positive. And at that time, the cost of antiretroviral therapy was $10,000 per person per year, far beyond what the average Botswana could afford. So it really was a tragic situation. The president of Botswana at that time, President Festus Mogae, was a real leader on this, trying to get the people to wake up to this threat. He talked very candidly in speeches about the threat of blank extinction of the Botswana people, as he put it. And I ended up making that my signature issue, because it was the one thing that was really catastrophic for the country. At that point, when I arrived there in December 1999, you couldn't even get tested in the country for HIV. You could get tested by your doctor, who would have to then send the blood sample to South Africa, the neighboring country to the south, just to find out the results if you were HIV positive. So what we ended up doing through the use of a wonderful organization that CDC had set up, the US Centers for Disease Control and Prevention had set up this BATUSA operation, which was a cooperation between CDC and the health ministry called BOT USA, BATUSA. And we had a great cooperative relationship with the Minister of Health, Joy Pumapi, who is still prominent in global health circles. And with that, we were able to build voluntary counseling and testing centers so that people could find out their status, because the vast majority of people when I got there didn't even know whether they were HIV positive or not. So with those voluntary counseling and testing centers, the buildings were built through the U.S. military, through our Defense Attache's office and Office of Development Cooperation, and using military humanitarian assistance funds. And then they were staffed and equipped by CDC. And we would always have a big opening with speeches and balloons and celebrations whenever these came about. I remember we even convinced President Mohai to come to the one when it was opened in his home district where he was originally from. And this was before the creation of PEPFAR, the President's Emergency Plan for AIDS Relief. So this was the best we could do at that time. Antiretroviral therapy, as I said, was beyond the capability of most people to afford. And then one final note on this, I really think it's one of the seminal events in this history at that time of the fight against HIV/AIDS occurred in January of the year 2000, when the US ambassador to the United Nations, Richard Holbrooke, arranged for the first ever meeting of the UN Security Council on a matter of health as an issue related to the maintenance of international peace and security, which is what the UN Security Council is for. And Vice President Al Gore went there and gave a speech on this. Kofi Annan gave an eloquent speech about why this was a national and international security issue, because it wasn't just a health issue. You had this situation where there were cabinet ministers in some countries who were dying of AIDS. You had this threat of political instability that people saw as deaths were increasing. I remember talking in Botswana to a company that, an insurance company, that under normal circumstances would have 500 employees, but they told me they were hiring 600 employees total because of the turnover that you would have due to people dying from AIDS or taking care of loved ones who were sick from AIDS and unable to go to work. And just because of all those absences and deaths, you had to have a higher workforce just to keep a trained workforce available. There was a time when I went back to Botswana 10 years after I was there, and in a meeting with the then president, Ian Khama, he was talking about that period when I was in Botswana, 1999 to 2002, and talked about how every Saturday you would see motorcades going to the bush, to the villages, with which were funeral processions. People who had died, they had moved from their village to the city of Gaborone, died, and then on Saturday there would be this procession back to the village to bury the person. It was there was even a book that was produced by some of the global health HIV/AIDS experts in Botswana called "Saturday is for Funerals." It's a very sad time. But that's how I first got involved in global health, and saw it even then as a matter of national security, international security, through the lens that I call global health diplomacy, seeing the leadership of President Mohai on this. And I'd be happy to talk a bit about his leadership if you'd like.
Yeah, definitely. Because one of the things I'm going to want to go into, and we can do that in a little bit, is the case study per Indonesia and H5N1. But yeah, could we start off in general by defining what global health diplomacy is in general? If you just take us a little through what it means to you, and sort of how you created it, the term in the first place.
No, happy to. I don't have an MD degree. I don't have a master's in public health. I'm a diplomat. Sure. But I'm very engaged on global health issues and have been, in, as you pointed out in my bio, ever since I arrived in Botswana in 1999. And what I see is this the nexus between the work of the technical experts and the leadership that's needed, because you can really fall down in your response, whether it's to a pandemic such as the coronavirus, COVID-19, or whether it's to an HIV/AIDS epidemic, you really fall down if you don't have the leadership. And that's where diplomats come into play. That's where others come into play. I had my time with Bill and Melinda Gates Foundation. I went with Bill Gates when he met with the president of Nigeria, good luck, Jonathan, in Abuja. I went with him when he met with the president of Chad, President Deby, in N'Djamena, and he was engaging in that advocacy effort that I like to think of as global health diplomacy, with the head of state to get them to be engaged on key issues. For him, his number one priority back then was made clear, it was polio eradication. But to me, the biggest difference you can find was when I was in Southern Africa, in Botswana. President Mogai, as I said, had this leadership role on HIV/AIDS. He won a global award for his work on this. And meanwhile, in South Africa, you had a situation where the president of South Africa, Thabo Mbeki, and the Minister of Health, Shabalala Msimang, questioned whether HIV caused AIDS. And there are people who will claim that hundreds of thousands of South Africans may have died because of the lack of a good response on the part of the South African government during that period. I've never served in South Africa. I don't want to make those kinds of judgments, but it was clearly a tragic situation when you didn't have the leadership at the top. And it was really brought home to me back in the end of March of 2002 when I was in Gaborone. And the Secretary of Health and Human Services at that time, Tommy Thompson, led a delegation of about 50 top US public health experts to several countries in Africa. If I recall correctly, Tony Fauci, Deborah Birx, and other key people were on that delegation. And they went to South Africa before they came to Botswana. They were very depressed in South Africa. I was told that they didn't get a meeting with President Mbeki. They had a meeting with the Minister of Health, and she was very unhelpful. And they were very dispirited when they arrived in Gaborone after visiting South Africa. And then they get to Botswana, and here you have this dynamic Minister of Health, Joy Phumaphi, strong leadership on the part of President Mogai, and a real goal on their part to tackle that HIV/AIDS problem in Botswana. And it was very enlightening for them and was very positive. And it ended up resulting in greater efforts on the part of the Bush administration, President George W. Bush, on stopping the link between maternal to child transmission of HIV/AIDS. And then less than a year after their visit, he announced the creation of PEPFAR in his State of the Union address in January 2003. So it's that leadership level and how to work that. And it's not just a matter of, well, let's have a good leader, but there are so many different aspects to it. For example, it's easy if you're a technical person to complain that the health ministry needs more funds. But if you're the ambassador, you've got to figure out a way, if that's what you think is the proper goal and in the US government interest, you want to figure out a way to get that health ministry the increase in budgeting. Maybe that means talking to the finance minister or the prime minister or the president, or maybe it means channeling some development assistance to the health ministry. But there are ways that you can work at these different levers that are beyond the technical issues of public health and really involve what I call global health diplomacy.
Excellent, excellent. I appreciate you laying that groundwork. So, Don, that leads to a really important piece of sort of literature that you wrote. I mean, during your time at the Bill and Melinda Gates Foundation, you author a section of a book that's called Negotiating and Navigating Global Health, Case Studies in Global Health Diplomacy. This is 2012. There's also a presentation you gave at Columbia University. where you basically go into sort of details and negotiating issues related to pandemic influenza preparedness, the sharing of influenza viruses, and access to vaccines and other benefits. And here you tell this amazing story of, there's H5N1, we have a nasty zoonotic spillover event found in poultry, making its way to humans. You have all sorts of preparedness strategies and so forth set up, but at the same time, you're running into issues, and this particularly because things started down in Indonesia, where the Indonesian government is concerned not just about, okay, if we give you this virus and you can make all these vaccines for us, are we going to get the vaccines back? And this leads to the Jakarta Declaration and this concept, which was amazing. There's something called viral sovereignty, which strangely enough, I was in the, for a few years of my life, I was in the bioprospecting business, looking at natural products and things like that. And a lot of countries obviously have sort of biodiversity sovereignty. If you take this flower out of our country and you make $1 billion drug, we want to see something from that. In this case, right, I mean, we had a deadly virus, a spillover event. Walk us a bit through this story, because I'm sure, like, when you entered this situation, you probably didn't think you were going to be, getting sort of the pushback at this level that you ultimately ran into. But talk a little bit about this situation, if you would, because I think it's an excellent case study on what the global health diplomat can run into.
Yeah, because of the work that I'd been doing earlier on HIV/AIDS, and both in Botswana and at the start of PEPFAR, and as Deputy U.S. Global AIDS Coordinator, when avian and pandemic influenza became a big issue because of the H5N1 virus, the State Department asked me to become the special representative on avian and pandemic influenza. A woman had been, a good friend of mine, Nancy Powell, had been the special representative for 6 months, but then she had to move on. And they asked me, because of my background in global health, to work on this. It was a high priority of the President of the United States. And in fact, I even wrote an article that was published not too long ago about how George Bush really cared about pandemic preparedness, far different from some other leaders around the world, and when COVID came along. And it was amazing. He had read the book by John Barry that was talking about the 1918-1919 pandemic, and became very worried about what could happen. And the main focus at that time was H5N1, because that was known as bird flu. And as you point out, was killing millions of poultry, and some people were dying, humans were dying, if they'd been very close to the poultry. There was a little bit of human-to-human transmission, which is a key concern for a potential pandemic, but not much of it. So far, it hasn't, that H5N1 virus, as we speak, has not mutated to become sustained and efficient human-to-human transmission for the next pandemic, but you never know, it may. And there was a major effort that went on with the Homeland Security Council, as it was then called. Now it's part of the National Security Council, and a huge strategy for dealing with this potential of a pandemic. And that strategy made very clear that the State Department coordinates the international engagement of the United States government in this. It wasn't the Department of Health and Human Services, it was the State Department. So that was my role. I was the top person in the State Department working full-time on this. I was working for an Undersecretary of State for Global Affairs who worked directly for the Secretary of State. I was working full-time, heading what was really a task force called the Avian Influenza Action Group to deal with this need to prepare for a potential pandemic. It was a major operation. I hosted an interagency meeting once a week with all of the different US government agencies that were involved, the Homeland Security Council, the National Security Council, CDC, Health and Human Services, the Department of Defense, the Department of Agriculture. This was a One Health issue because you had the connection between animal health and human health. The people from the U.S. Department of Agriculture told me that they'd never been in the room with somebody from the Department of Health and Human Services before. It was really something to try to get them to cooperate and work together in this preparedness effort. So we're going along on this, and then within my first 6 months or so on the job, the Minister of Health of Indonesia, Siti Supari, decided that she was unhappy with the situation where we had placed so much emphasis on the need for virus samples from Indonesia, where most of the poultry were dying, and which was our biggest concern. And from her perspective, she shouldn't have to share these samples unless there was a guarantee that if a pandemic did occur, she, meaning Indonesia, would be near the top of the list, if not at the top of the list, to get any vaccines or antiretrovirals that would be created using those viruses.
Mm-hmm.
And that's what Richard Holbrook and Laurie Garrett described in their article as viral sovereignty. She was trying to say, we own these, why should we give them up for free? And then we're going to be last in line to get a vaccine. Now, the US government policy, and I had talks with the Secretary of Health and Human Services at the time, Mike Levitt, and with the Homeland Security Council, the US government policy was, no, we're not going to pay for these virus samples. And we're not, and you can't guarantee that once the vaccines are produced that Indonesia would be first in line. Instead, we should continue with a system that had been in place since 1948 when the World Health Organization was founded, which was the Global Influenza Surveillance Network, to allow the continued use of a continued free flow of virus samples. Because the sooner you get this sample, as soon as this mutation has occurred and the pandemic has begun, the faster you can create a vaccine. And weeks or months of delay will mean that there's a weeks or months of delay in people getting the vaccine, and more people will die as a result. So it was really important to the United States government to protect our people that we get these virus samples. This became a shorthand of virus sharing and benefit sharing when these negotiations started going on at the World Health Organization, because the Minister of Health didn't want to share these samples. They stopped sharing them. We took it to the World Health Organization, and she took it to the World Health Organization, and we had competing resolutions that we proposed for the May 2007 World Health Assembly on how to ensure that virus samples would be shared. And she, Minister Supari, working with others, were trying to insist that there would be benefits in return for this. And those negotiations took 4 years.
It's a health diplomacy 101. I mean, for everybody listening, I encourage not just to take a look at that case study, but also the presentation you give at Columbia is really a fascinating story of how also all the details behind this. So I appreciate you sharing that with us, John. I'd like to talk about a couple of the articles that you've written in the last couple of years that are quite prescient in terms of everything that's going on right now. And I think the one I'd love to start with is one you had in the UN Foundation's materials entitled, Despite Coronavirus Alarm Bells, Global Health Security Remains Underfunded. This is February 13, 2020. And the whole, the premise is that we have coronavirus, unfortunately, but there's other stuff coming. We don't know when, we don't know where from, but we need a so-called health security fund. And so I just did a couple episodes, one with Senator Lieberman and the other with the Secretary Shalala. They're both part of the United States Bipartisan Commission on Biodefense. Obviously, there's a lot of other sort of disease-specific initiatives out there in terms of the Global Fund, TB, malaria, HIV, and so forth. Talk us through what a health security fund for the earth would look like. Once again, keeping in mind that this would encompass not just sort of diagnostics and vaccines and antivirals, but One Health initiatives, agricultural, bioterrorism, sort of lots of stuff falls into everything in the health security basket. What types of things are you thinking about in terms of how this could ultimately work?
It's actually a huge area. And if you want to include the One Health concerns and the problems with animal health and the potential for crossover to humans, zoonotic diseases, it becomes so broad that the funding needs are just huge.
Right.
But at the same time, having come from my role as a diplomat, I'm very familiar with U.S. government funding and the Department of Defense funding, and so much effort and so many tens of billions of dollars are spent on nuclear weapons and prevention of nuclear war. And it's nowhere near as much money being spent to protect the public health people. And you can just look at, I call this global health security. You can just look at the threat to America when you have 1 million people dead from COVID-19.
Yeah.
And at the same time, it just never gets the sustained funding. The people who work on global health security talk about feast or famine.
Right.
You had this uptick in US government funding when there was the concern from H5N1, but then the pandemic that did occur was H1N1, called swine flu, 2009, 2010. It turned out to be a moderate pandemic. And as a result, a lot of us think it did more harm than good, because people thought, well, what's the big deal about pandemics? We can weather those without a problem. Funding went down. Then Ebola in West Africa occurs, and over 11,000 people died in Sierra Leone, Guinea, and Liberia. And suddenly we're worried about Ebola, and President Obama created the Global Health Security Agenda, and money was coming toward that. But then after a while, the Congress started saying, well, why don't you use this money for other things? And the funding went down. COVID comes along. Now suddenly the funding goes up. What we need is sustained funding. And actually, since I wrote that article, there's been some real progress made in that the World Bank is about to create something called the financial financial intermediary fund, the fifth, for pandemic prevention and response.
Okay.
So that the World Bank, and they're still trying to figure out the parameters of the funding, will be in a position to provide money that will be available for pandemic preparedness and response. Now, what do you do in terms of this? One of the big things that the developing world wants to build into these kinds of things is equity. Mm-hmm. In the global north, much of the concern is security. We in the United States don't want to have our people dying from pandemics. How can we build up security? But the problem from a perspective of the developing world is they didn't achieve equity. They were last in line to get the vaccines, just as Minister Supari was saying back when I was negotiating with her in 2007 and 2008. The vaccines that were created for COVID didn't go quickly to the developing world. It was slower, and still you find that in sub-Saharan Africa, the vaccination rates are far lower than they are in Europe and the United States. So one way to try to bring in that equity is to increase vaccine manufacturing capacity in sub-Saharan Africa, so that they don't have to rely on countries that may try to keep most of the vaccines for themselves in the initial production. Though that's one of the examples of what can be done in terms of preparedness. And it's really the kind of thing, we know there's going to be another pandemic. We don't know how serious it will be, and we don't know when it will be. And we need to have a ready level of preparedness, so that we're alert to these things, that that the laboratories and surveillance networks that are available around the world are capable, that they are transparent under as they're supposed to be under WHO's international health regulations, and that we have a situation where these whenever there is an incipient pandemic, the world is put on notice immediately and can jump into action. Besides the funding issues that you mentioned, though, there's one other thing that's important, which is that the World Health Organization is not only looking to revise the international health regulations, but also considering some kind of pandemic accord. It could end up being a pandemic treaty. And those negotiations, as multilateral negotiations tend to do, are going to go on for 2 more years. But plan is that there will be an agreement. We don't yet know the nature of it, if it's going to require the U.S. for the Senate to ratify this treaty, as would be the case in this country, or if it's going to be something that will be accepted and a country has to opt out instead of opt in for the treaty. So there are lots of things to be decided yet, but that is another way in which the world is moving toward pandemic preparedness. I still, in the back of my mind, am concerned about the long-term funding, and which is why I think the World Bank as an institution having this financial intermediary fund is an important development, because once you have it built into there, it's likely to be able to maintain that level of funding. But in terms of governments, including the U.S. government, it's still likely to suffer from the feast or famine syndrome.
It's going to be interesting to see the World Bank initiative evolve and see what comes out of that. But I appreciate you mentioning that too. So far, we've on this show we've talked H5N1, H1N1, Ebola, obviously COVID. We've touched on a lot of the other viruses that have been new to the public sphere in terms of SARS and MERS and Zika and what's been happening in the last couple of decades. The one that we don't expect to hear about is polio. And you just wrote a piece, I think, a couple of weeks ago in the Council on Foreign Relations Think Global Health magazine. New polio cases highlight the urgency of eradication. Jonas Salk did his thing a long time ago, and it's what I had Rosamund Lewis on the show a couple weeks ago from the WHO, and she's in charge of the smallpox directorate there, and I was joking around with her, what happens in the directorate? We eradicated that, and polio is one of those ones that always sat in the back of my mind. I think we've almost eradicated that one, and here we go in the wastewater, not just in a variety of countries, but right here in New York City, New York State. What's happening with this? I mean, this, you have experience in the Polio Partners Group, as I mentioned in the intro, the Global Polio Eradication Initiative. Eradication is a different thing than just vaccinating some people. Talk a little bit about what's happening here, and there must be some shock and awe with this one coming back, I gotta say, into the public, for.
Yeah, actually, I think I wasn't as shocked as some other people, just because we haven't eradicated polio, and so it can occur in different places, and now even in New York State. But it's really a wonderful success story and a sad story, because it hasn't completed it. The Global Polio Eradication Initiative was created in 1988 when the World Health Assembly, all the member states of the World Health Organization, declared the goal of eradicating polio. And when I got to the Gates Foundation in 2009, after retiring from the Foreign Service, that was the first time I ever dealt with polio. And as I said, it was Bill Gates' highest priority. And then you had 4 countries where it was still endemic: India, Nigeria, Afghanistan, and Pakistan. The program has made incredible progress. It's no longer endemic in India. We're talking about the wild polio virus, and it's no longer endemic in Nigeria. And you're down to 2 countries, Afghanistan and Pakistan, that still have the wild polio virus endemic, where it's never been eliminated. And the numbers are just incredible. When you look back at what happened In polio in 1988, when GPEI was created, there were over 350,000 people a year who suffered from polio. And it's a disease that causes paralysis and sometimes death and is incurable. The vaccine, as you point out, whether it's the Salk vaccine or the Sabin vaccine, the injectable inactive polio vaccine or the oral polio vaccine, it's easily preventable through those vaccines. And yet you still have some people dying from it because they haven't been vaccinated, or still have some people becoming paralyzed because they haven't been vaccinated. And the numbers of dropping from 350,000 to in the dozens, it's just a huge drop. But the problem now is, when you're talking about a country that's now run by the Taliban, and when you're talking about some remote parts of Pakistan, these are areas where it's not all that easy to run polio campaigns. And as the numbers get fewer and fewer, it's also less of a priority for the families. When you have a mother and you say, here, we have to vaccinate your child against polio, and she has never seen a case of polio because there are very few left in the country, but she doesn't have clean water and sanitation and doesn't have enough food to eat, and people are dying from measles or other diseases, it's pretty hard to say that your priority is a global good. We're trying to eradicate polio around the globe. Here, polio's got to be a priority. So what the polio program has had to do in these last stages of eradication is to become much more integrated with other programs that are being worked on by Gavi, the Vaccine Alliance, by the World Health Organization, by UNICEF, in terms of other vaccines that are included, providing bed nets against malaria, whatever the case may be, to have a more integrated program to get to those last stages and to finally eradicate it. Maybe this case that we've had in New York State and in the wastewater in London and in New York and problems in Israel, maybe those will be the wake-up call that we finally will be able to finish this. But it's still very hard in those last bastions of this wild polio virus. And in a lot of respects, and this, again, this is my lens looking at things from a diplomat's perspective, it's not just a public health issue. It's a security issue. Recently, very recently, you've had some security officials who were guarding the polio campaign who were shot. You've had situations where you're trying to deal in areas of conflict. It's a humanitarian issue, a political issue, a security issue, a diplomatic issue, and a health issue. It's because we know how to put 2 drops of oral polio vaccine into a child's mouth. That's not the question. The technical question is easily answered. It's the broader context that has to be dealt with. And then one other aspect of this that is very important to try to understand is by using the oral polio vaccine, and this gets into some of the technicalities, that has a very positive effect because when people then can, that's in their stools, that polio vaccine will come out, and it actually broadens the vaccinations against polio in a community that has poor sanitation. But the problem is, in very rare cases, that oral polio vaccine can mutate and create a new polio case called vaccine-derived polio. And that's what we're experiencing when we talk about it in the wastewater. It's circulating vaccine-derived polio. That is now coming back in countries because of it gets kind of complicated in terms of the oral polio vaccine 2 strain. But it's coming back in some countries, and we now are trying to fight on 2 fronts. One is to eliminate the wild polio virus that remains in Afghanistan, Pakistan as endemic, and a few cases have occurred recently in Mozambique and Malawi. Mm-hmm. And the other one is to tackle the circulating vaccine-derived poliovirus that has occurred in over a dozen countries.
John, could you say a few words about the triple billion and the World Health Organization / UN Sustainable Development Goals? You wrote this piece in 2018 on the ambitious transformation of the World Health Organization. You're pointing out, look at health emergencies, clearly a major pillar there, but they do a lot of other stuff, universal health being one of them, and then sort of this global initiatives they have on just healthier populations, non-communicable diseases, mental health. They have a huge push nowadays for healthy aging, and which is a hot topic on our show. Say a few words about sort of your perspective on how things are going, transforming per these other well, they're all emergencies in a sense, but the non-infectious disease component of WHO, because they do a lot more than that, but we just, we've been so focused the last couple of years on obviously COVID and now monkeypox.
Yeah, I tend to even spend my own time on infectious diseases, as we've been saying, starting with HIV/AIDS and threats of pandemics and other things. And yet you still have such a great concern for non-communicable diseases, and particularly in the developing world, because it's been so easy to focus on infectious diseases that there hasn't been enough attention to concerns about whether it's diabetes, heart attacks, etc. You've got concerns about smoking and trying to include efforts to reduce smoking so there are fewer cancers. There's just all kinds of things that are needed in the developing world. And there's also a concern now for antimicrobial resistance, which is where antibiotics become unusable because they've developed resistance so they're no longer efficacious. And I really give the Director General of the World Health Organization, whom I've known for 10 or 12 years, Dr. Tedros, great credit for how he was able to package this in those three bundles that you mentioned, and because it really did cover everything. The problem, I have to say, is that COVID-19 has been so dominant as the public health issue, and there's been such a lack of emphasis on the other things. Even talking about infectious diseases, immunizations. The World Health Organization and UNICEF came out with a report in the last month and a half about, it's called the WUNIC report, WUNIC, in which they talked about the decline in immunizations and 5 million fewer children were vaccinated against measles in 2021 than in 2019 because of the COVID pandemic. So the COVID pandemic has distracted from some basic efforts, whether it's for non-communicable diseases, whether it's for vaccinations or et cetera. The governments and the World Health Organization, UNICEF and others have tried to keep going on these, but you really couldn't ignore COVID. In fact, the GPEI, the Global Polio Eradication Initiative, was quite good in allowing its staff to work on COVID, even though they were funded for polio early in the pandemic. But the progress on those three triple billion goals of Dr. Tedros has been delayed clearly because of COVID. They're very good goals, I believe, and I'm hopeful that progress will resume. But it's not been what we had hoped because of the distraction, shall I say, millions of people dying of COVID. The world had to make that a priority. And sadly, some of the other programs have, in public health have suffered as a result.
One, sort of just coming full circle now and coming back to you, John, anything that I missed in terms of other initiatives, the United Nations Foundation, per the global health diplomacy that you're involved in. I mean, I also mentioned at the beginning that you are used to chair the Measles Rubella Initiative. I don't know if you want me to ask about that, or maybe we could just wrap up with that. But really, anything else that I didn't touch on that you want to mention that's happening for you in 2022, please take the floor. I'd like to hear other things that you'd like to bring up.
Well, thank you. As I said, I've been involved in polio eradication and measles elimination, and I'm still very hopeful that we'll make great progress on those. One of the reasons I'm hopeful for polio is that we are down to 2 endemic countries, as I said, for wild polio virus. And when I first started working on polio in 2009, it was 4 endemic countries. You can just see the progress, but we still haven't made it all the way. And we really have to, and we just got the wake-up call, as you pointed out, in New York and elsewhere. On measles, one of the reasons I'm positive there is because of the big effort called Immunization Agenda 2030.
Okay.
And this is something that others and I at the UN Foundation work on with the World Health Organization and UNICEF and others, but it's based at WHO. And it's a broad effort that is intended to build immunization systems within broader health systems, part of universal health coverage. And that Immunization Agenda 2030, its goal is to greatly increase the level of vaccinations, because you can make a case that one of the best ways to prepare for a potential pandemic is to have high levels of routine immunization, as they call it, the essential immunizations that a child needs, so that when people do become sick from a coronavirus or whatever, they won't be dying from vaccine preventable diseases that because they've been vaccinated against them. Vaccinations are so important. It's really a magic bullet. Bill Gates is speaking positively about this. Dr. Seth Berkley from Gavi, the Vaccine Alliance, is a strong proponent of it. Dr. Tedros and many others. It's just so important to have high levels of vaccinations. And it's not easy to do, especially when you have to have a cold chain, because some vaccines require a refrigeration.
Sure.
And that cold chain, as we saw, including, as we saw with the COVID-19 vaccines that required cold or even ultra cold temperatures, it's very difficult sometimes to get beyond the capital cities and some of the bigger cities in the developing world. I've visited, for example, in southern Ethiopia, some health clinics, and you go there and they've got this kerosene-operated refrigerator because they don't have reliable electricity, and they're just hoping to keep the vaccines cold, and it may or may not work today. It can be very difficult when you don't have a good electrical grid, and in a lot of rural parts of Africa, where I spent much of my career, you don't have that. And there's some really great infrastructure challenges to trying to increase the vaccination levels, whether it's infrastructure, whether it's staff, whether it's laboratories, et cetera. So Immunization Agenda 2030 is really meant to look at this in a broad way. And the Measles and Rubella Initiative, while it has been in existence since 2000 and has had great success, we're working with Immunization Agenda 2030 in order to try to broaden that partnership for measles and rubella through what we call IA 2030. And I really think that's a very positive thing. We have at the UN Foundation a program called Shot at Life, which is a promoter of vaccines. We also have United to Beat Malaria, which is our effort to try to provide bed nets and other ways in which we can try to tackle malaria. We have a lot of different programs out there. And as we emerge from this coronavirus pandemic, I think we're going to be making progress in these various areas. And that includes those triple billion goals that you mentioned earlier from WHO's Director General, Dr. Tedros. So I'm optimistic at this point. It was such a shame that we went through this COVID-19 pandemic. I gave a speech at Chatham House in 2007 in which I said we need to be prepared for a pandemic, even if it's not from the H5N1 virus. We need to be prepared. Others were giving speeches back then, and the warning signals were there. We weren't prepared enough, clearly, not when you have 1 million people dead just in this country. And I'm hopeful that these new efforts, whether it's through the World Bank and other means of funding things, that we'll have more, even if not enough funding for pandemic prevention, preparedness, and response for the future, that will make the progress that we're talking about on these other diseases, whether it's non-communicable diseases or infectious diseases, et cetera, and that we'll be able to move forward as we recover from this pandemic.
Outstanding, really outstanding. John, it's been great listening to your story, listening to all your experiences and learnings, and really appreciate everything you've done to date through your amazing career. You know, not just on the public health front, but obviously for your service to the United States and obviously beyond. So really, really wonderful, and you know, wishing you the best with everything you continue to do with the UN Foundation. For everybody that is going to be listening to this particular episode across the various podcast networks or watching on our YouTube channel, again, you've been listening to Ambassador John Lange, Senior Fellow, Global Health Diplomacy, United Nations Foundation. John, again, I want to thank you for taking time out of your schedule to come talk to us and educate us for a little while on these topics. Obviously, thank you for everything you've done and continue to do. And as we say on our show, thank you for helping to create a better tomorrow through what you're doing. A very, very inspiring story.
Well, thank you, Ira. It's very nice of you. And I really appreciate the invitation, and I really appreciate the good work you're doing with the podcast.
Good seeing you.